Sorry.
You are live now, sir.
Okay, so good evening, everyone. We are ready with yet another episode of Contact Lens Learning course. And thank you for all the positive reviews that you people are sending me through WhatsApp. And today, our moderator is Dr. Rebecca Dhiman, and our chairperson is Dr. Rohit Saxena. It's a very important topic, and probably currently it's a hot topic. So I'll request our chairperson, our president, sir, to say a few words. Then I would request Dr. Rebecca to introduce the speaker and carry forward the session.
Thank you, Praful. And as you rightly mentioned, both the topics in this course, contact lens ortho K as well as myopia, are two extremely important and rapidly growing issues. So, one, childhood myopia is rapidly increasing, and I think it's really important for all of us not only to be aware about it, to counsel our patients and our children, and also to know about the opportunities available for their prevention and management. And ortho K again is again something that is rapidly coming up as a alternate to the pharmacological and spectacle interventions that we give. So it will be very good to know about the experience Vikas has, and which is quite phenomenal on managing on dispensing ortho K and managing myopia. So, Dr. Rebecca, please go ahead and start the session.
Thank you so much, sir. Indeed, as sir has just mentioned, that myopia is becoming an issue, and now today we would be traveling down the less explored terrains, I would say, in myopia, which is the contact lens fittings in myopia for the myopia control. And I think none other than it is Mr. Vikas Chaturvedi, who has immense experience in the field. He has been an optometrist and RPC alumni, and he's been constantly working. In fact, one of the first few to start the orthokeratology, popularizing orthokeratology here in India. And he's the founder and director of V Square. And he has done a myopia control course from none other than the Brian Holden University. So I think best way to learn about the contact lens fitting would be from from Mr. Vikas. So Mr. Vikas, I would invite you for your talk on myopia control and orthokeratology.
Just
Thank you, Dr. Rebecca.
Yeah, Vikas, please share your PPT. In the meanwhile, we have our few of the panelists here. Vikas, you can start sharing your PPT. Dr. Aditi, Dr. Ikeda, and Dr. Anu Malik. And thank you all of you for joining. And Rebecca, once the talk is over, you will have to carry forward the discussion with this panelist. Okay.
Right. Thank you, sir.
Okay. Thank you, Dr. Rebecca. And thanks, DOS, for inviting me for this talk. I want to thank special thanks to Dr. Prafulla, sir, because he has given me this opportunity to talk on myopia control and orthokeratology. I am Vikas Chaturvedi, and the topic which I am going to cover is myopia control and orthokeratology.
You can start sharing your screen, yeah. Mr. Vikas.
Screen is not okay.
There would be a green button on the lower side of your screen. A green arrow.
You had just shared, so.
Yeah, I shared.
So is the page which is showing all the
the
videos?
Just now.
Yeah. So there's a green arrow at the bottom of that page.
Yeah.
Yeah.
Not there, right?
Right.
Okay. So to start with my presentation, we know that why myopia control is important. As per Brian Holden University, we know that by 2050, 50% of the world population will be myopic. And most importantly, 10% of the population will be high myopic, which is a very big concern for all of us. So my topic, which I'm going to present more on, I'm going to present on the theories of myopia control related to orthokeratology. The first theory, which we all aware about, the hyperopic defocus theory by Professor Earl Smith. Apart from that, I'm also going to cover about the preferential visual span theory by Dr. Arthur Tung and high myopic defocus theory. So as per Professor Earl Smith, he did a study on monkey's eyes to understand the role of peripheral retina on the myopia. So in his study, he found that a very interesting thing, that the functional phobia is not essential for normal axial development. Rather, the peripheral retinal receptors provide the signal for the eye to grow. So based on this theory, if we see emmetropic children, so in emmetropic children, the peripheral, if you see the peripheral defocus, it's actually a myopic one. So in emmetropic children, the retina, the peripheral rays are focusing in front of the retina. But once a children develops a myopia, and we correct that patient with a myopic correcting lenses, we see that the peripheral defocus is now forming behind the retina, which is known as hyperopic defocus. So if we correlate this theory with Professor Earl Smith theory, which says that the peripheral receptors are actually responsible for the myopia to grow. So in this case, the signal which is providing from the hyperopic defocus is actually stimulating the eye to grow. Now, by any chance, so this is how the peripheral defocus theory says that in case if you go with a myopia correcting lenses, then the peripheral rays will focus behind the retina, which is also known as a hyperopic defocus. Now, by any chance, if you can convert this hyperopic defocus to a myopic defocus, then the peripheral receptors will not get the signal for the eye to grow. So this is as per Professor Earl Smith. So based on this concept, the orthokeratology works. So in orthokeratology, we try to achieve a bullseye pattern. And in bullseye pattern, the central cornea becomes flattened based on the target refraction, and the mid-peripheral area is steepened, and that actually induces the more myopia in the mid-peripheral zone and helps in converting the hyperopic defocus to myopic defocus. So based on this theory, we can understand that myopia can actually be controlled with if you can convert the hyperopic defocus to myopic defocus. But there are other studies which say that even a study done by in LBPI by Dr. Pawan Chella, who found that a very interesting fact that in myopic children, only 30% of the myopic children only have a hyperopic defocus. So, but we know that orthokeratology works in mostly all the cases. So why it is so? So to understand this, there is a theory given by Professor Arthur Tung, known as a preferential. Comprehension is the major reason for human myopia. And the research done by Professor Earl Smith is basically on the monkey eye. And we know that that is not the only reason, because monkey means any animals don't read. So to understand this theory, what Dr. Arthur Tung has done, he tried to understand that what are the other areas which can help us to understand the control of myopia with orthokeratology. So we all know that the phobia is not the only point where the reading happens. Actually, it happens on more than that. So that is why we call it as a visual span. So visual span can help the paraphobial area for reading a wider visual span with less central phobia stimulation and relief accommodation. So if you can utilize the paraphobial area for reading, then actually we can increase the visual span, and this is what the Professor Earl Smith has done with his patented technology with preferential visual span. So in preferential visual span, when paraphobial focus is being much clearer than the phobia for near vision, the superior image may draw attention to the off-axial locus for reading comprehension. What he mean to say that if by any chance we can make an optics in such a way that the rays which is actually going from the off-axial location, not from the on-axis of the not from the visual axis, but the off-axial locus, and it forms an image on the paraphobial zone. And that image, if the patient can use, if the child can use to read, then that help us to control myopia. I will explain this in upcoming slides. So basically, if we talk about the preferential visual span, preferential visual span is actually increasing this visual span of reading. That means when we are looking at one particular page, suppose I am looking at this laptop right now. So I am actually able to read a whole this slide without moving my eye. So that means that is happening because it is not the phobia, but the paraphobial area is also responsible for reading. So that is what the preferential span is all about. The range of letters formatted as in text that can be read reliably without moving the eyes. So the concept of preferential visual span says that if we can focus the images on the peripheral visual, on the peripheral part, means that means parafoveal part of the phobia, then and that image is more clearer, then that helps the children to read, and in that case he will also relax his accommodation. So to relax his accommodation, what we have to do, we have to give a power in that parafoveal zone more than 2.5 diopter, because that is what an accommodation requires. So for reading at 40 centimeter, suppose we are reading at 40 centimeter, so we need at least 2.75, 2.5 diopter of power. So now if we can give a image focus at parafoveal area, which is more than 2.5 diopter, so basically in his optics, what he have done, he has given an addition of somewhere around more than 4 diopters, means 2.5, more than 2.5 to 4 diopters, and that actually helps the children to read without using the accommodation. So basically the preferential visual span helps enables the parafoveal zone for reading. To make it more clear, I will just explain this slide. So we know that the resolution at phobia at the 2-degree visual axis is somewhere around 6x, that means 20 by 20, when on the on axis image. But if we can make a para axis image at the parafoveal zone, which is in the range of 5 degree to 10 degree, so the best corrected vision, the resolution at will be somewhere around 2020 to 2050 in that area. So that area can be used for reading, and that can be done by increasing the visual span, which is known as a preferential visual span. So this is the retinal image. From here we can see that what are the locus of different zones like foveal area, parafoveal area, and perifoveal area. So when we talk about orthokeratology, so we all know that orthokeratology are basically multifocal lenses. So in multifocal, the simultaneous multifocal, we talk mostly about the simultaneous multifocal in orthokeratology. The traditional simultaneous multifocal lenses are made in such a way that made on the concept of that the distance, the reading is actually from the foveal area. So to make that thing happen, they have used both the images. They have mixed the distance and near images on the foveal area, and which actually creates a blurry image, and that is why how the image is perceived by the patient, and that can cause some halos and glare in that case. Not only that, even the contrast sensitivity of the traditional simultaneous multifocal lenses are not so significant that actually helps to differentiate the distance and near object. Apart from that, in traditional multifocal lenses, we have seen that the additional power is somewhere around 2 to 2.5 diopter. That also induces some of the accommodation of the children. The idea of using the parafoveal, this preferential visual span, is also to take care of the accommodation. So the preferential visual span is made in such a way that it approach if using the preferential visual span device, so that the brain has the capability of decoding the off axis, especially the para axis, which is located in the parafoveal zone, and helps to differentiate both the images, that is both the reading and distant images. So the next thing is that Professor Arthur Tung also want to correlate this with the M pathway. So M signal, so we know that there are two pathways, the P pathway and M pathway. So M signal is the most abundant. We know that it is more abundant in the phobia, and it simultaneously reduces significantly in the parafoveal zone. So can we slow down myopia progression by reducing the M signal? So this is what he also used this concept to understand the preferential visual span, and use this technology in his device known as preferential visual span. So to understand this, so this is an image, and we know the Toxler fading effect, which actually, if you look at the center without moving your eyes constantly at the center object, then after some time you'll see that the peripheral images blur, so it actually fade away. So this is known as the Toxler fading effect, and in that what we know that it's because of the pathway. fails to erode the P pathway. So M pathway is basically for motion and P pathway is mostly for the contrast. So if based on this toxicity feeding effect, if you look at the center object, then the M pathway will fail because there is no movement, because we are actually asking the eye to not move and it just fixed on that center object, and that is how the M pathway fails and it will fails to erode the P pathway. So that is how the fading effect, toxicity fading effect comes into role. Now, there is another concept known as ICS, that means intermittent squint. So in that, we have seen that the accommodation drops in ICS also. So in ICS, if you see, the ICS also is linked to the anisometropia. Why I'm saying this? Because there is a study done which says that in case of ICS, we have seen that one eye is actually developing more myopia compared to the other eye, which is not affected by the ICS. So why it is so? So to understand this, we know that in case of ICS, there is a less M signal. So if there is a less M signal, that means your accommodation also relax. And if the accommodation relax, then that eye don't progress for myopia. At the same time, the other eye, which is having the same environmental and other factors, the other eye starts developing myopia. So using this concept, what Dr. Arthur Tung has done, this parafoveal area, which is having a less M signal, and if you can create an image, that means the reading image is created in the parafoveal zone, then that also can relax the accommodation because the M signal is very, very less in parafoveal zone. So these factors are actually helping to control myopia. So apart from the defocus theory, the preferential visual span theory also helps to control myopia by increasing the preferential span. That means by increasing the visual span for reading object and relaxing the accommodation. So from this, we can also understand that, as I already mentioned, that everything was same in case of ICS. That means the hereditary, nutrition, reading activity, everything is same, while one eye develop myopia and the other eye don't develop myopia. So myopia progresses faster in the fellow eye which doesn't have the ICS. So based on this concept, the preferential visual span help us to take care of the myopia, that means to control myopia. So this is the patent certificate for these preferential visual span lenses by Professor Arthur Tung. And for your information, all the GOV lenses which we have is having this PBS technology. This is the summary of this patent. Now, another factor which also helps to take care of the myopia, that means to control myopia, is the more myopic defocus. That means if you can increase the defocus, mean to say that if you can increase the addition power more in the mid peripheral zone, then that also can help to increase the efficacy of myopia. So to understand this, there was a study, Blink study, where what they have done, they have taken 3-4 different diopter lenses, additional additional power lenses like 2.5, 3.5, 4 diopter. And what they found that the higher additional lenses have the better efficacy to control myopia. To support this study, there is a study done on GOV lenses on 102 eyes, 102 cases, 204 eyes, where they have make two groups. One group having less than 9 years of patient, and the other group having patient less than more than 9 years. So in both the cases, they have tried to understand that what is the efficacy of myopia control. So that study says that 87% of the patient having this particular lenses can slow down the progression of myopia. But why it is so? Why this patient is having more control? Because if you see the study done on myopia control, the efficacy varies from 50% to 87%. So this basically depends on the more we can give a myopic defocus, the better will be the efficacy. So to understand this, there is a concept known as ratio between the REM steepening and treatment zone. So if the ratio between the rim stiffening, that means the mid peripheral zone, and the treatment zone, if the ratio is between 1.5, 1 to 1.5, the efficacy of myopia control is lesser. And if the ratio is more than 2 to 2.5, then the efficacy is better. So this is an example of a design where we can see that the target refraction is -3 diopter, and the technology for this particular ortho-K lens is having a 4 curve lens. And if you see the rim stiffening value versus the treatment zone, the ratio is 1.5. This is the another example with -3.25 diopter. In this case also, if you see the ratio of rim stiffening versus the treatment zone is somewhere around 1.3. 1.3. Now, in this case, if you see, this is a high myopic lens, high myopic patient, so power is -7 diopter. In this case, if you see the rim stiffening value, which is 58.5, that means 16 diopter steeper, and the treatment zone is 7 as per the target refraction, the ratio comes somewhere around 2.3 to 2.3. The same if we do with a low myopic patient, like a power of with -2.75 diopter, then in this case also, if you see the value of rim stiffening versus the treatment zone, it is 3.6. So this, if you see all the GOV lenses, they have a rim stiffening value more than 1.5, that is in the range of 2 to 3.5. So this also helps us to understand that the myopia progression, means the efficacy of myopia control can be increased if we increase the ratio between the steep rim and the treatment zone. Now, apart from the orthokeratology, the same concept of preferential visual span can also be used in other devices. One of them is the soft lens, which is known as SMR. So this is actually known as the soft. This lens also mimics all the optics of orthokeratology lenses. And if you see in this case, the peripheral rim has a power in the range of 8 to 20 diopters. So this technology, this particular device also uses the concept of preferential visual span. And the best part of this lens is that since it's a soft lens, so we don't need lot of fitting criteria. Like this lens can be fitted very easily to the patient. It is just like a soft lens, and you don't need to go for fluorescein pattern and other procedure for fitting. So this is how the lens is. So they have done fluorescein pattern with a high molecular weight. Since it's a soft contact lens, so they have used a high molecular weight fluorescein to understand that how the rims is developed. So this is how you can see it just mimics the orthokeratology, where rim is more steepening, is having more power, which varies in the range of 8 to 20 diopter. And if you see the topography image of this case, so you can see that the mid peripheral is somewhere 51.39 diopter, and the flattening is 53 diopter. So how this lens is made? So it's a very simple design where they have makes a flexor in the 360 degree in the mid peripheral zone. So this is the flexor, which is 360 degree. That means all around the lens there is a flexor, and when you put the lens on the eye, so the tear accumulates, and that tear lens forms a tear lens. That forms a tear lens, and this tear lens is actually this area is actually giving more power because it works as a tear lens. So because of this, it also helps to control astigmatism. So even in the range of 1 to 2 diopter. So if a patient have the astigmatism, that also can be corrected with this particular device. But the limitation is only till 2 diopters. So the benefits, as I already mentioned, that it's more comfort for the patient, and it is a day wear lenses. It's not an orthokeratology, so it will not mold the cornea. So it's a day wear lens. It works on the preferential visual span concept. It stimulates the ortho-K in the sense that the treatment zone and the steep rim is in the ratio of 2.3, more than 2.3. And it also corrects the astigmatism. And the power, the most important factor, because we know that in orthokeratology, the correction there is a limitation in correction. It can't be more than 10 diopter, because if we try to correct more than 10 diopter, then the central part will become more smaller, and that can cause halos and glares. But in this case, if you go with a soft lens, the power ranges till minus 15 diopter. So there is a study where they try to compare the soft okay, that means the soft lens, with other modalities or other pillars for myopia control, and the results were very excellent, where they found that it's working better than the other modalities. So this study on 6 kids to understand the means how safe it is. So they found that this is a picture of the cornea and the sclera. So you can see it's very white. So there is no means congestion in the cornea. Now there is another concept which is very important when we go with any soft contact lenses. So that is known as the inward focusing. So there are a lot of multifocal lenses, soft contact lenses available in the market nowadays, which also helps to control myopia. So for that, to understand the efficacy of those lenses, we also need to understand that how well those lenses are related to the inward focusing. So this is a single vision lens. So if you see a single vision lens with different power, with -2, -4, and -6, the inward focusing is, there is a little bit of inward focusing in these lenses. It's not high. And if you see this graph, so this is the power graph and this is the retinal eccentricity. So as per Professor Earl Smith, the peripheral defocus is more effective if it is in the range of 20 to 30 degree of the retinal eccentricity. So anything in the range of 20 to 30 degree actually helps to have a better control of myopia. So if you see the single vision lens, so the single vision lens is having little bit of inward focusing. Now this is another design. It's a multifocal lens. But if you see this multifocal lens, this Proclear multifocal lens from CooperVision, so if you see this lens, so and if you try to understand the inward focusing of this lens, the high power lens is having a little bit of inward focusing, but the low power lenses like -2 and -4, they are all outward focusing. So so outward focusing is not going to help in case of myopia control. Now this is the soft lenses which we have just discussed, the soft okay. And if you see the inward focusing, it's very excellent. So as I already mentioned, is the power, the treatment power, the ream power of these lenses, that means the mid peripheral power is some in the range of 8 to 20 diopter. So that can be very much easily visualized with this study, where they have tried to understand the retinal eccentricity at 30 degree, 20 to 30 degree axis. So in this case, we can see that the inward focusing is better with soft okay lenses. This is again a comparison between 3 lenses which we already discussed. That means single vision, Proclear lens, and soft okay lens. Another study done on the peripheral refraction changes with different design in China. And though they also found that the inward focusing lens is the inward focusing factor with soft okay lenses is better than other multifocal lenses they have studied. So this is another study done by Juame. So where he found that the inward focusing lens is better, is more with the soft okay lenses. And now this is a comparison of different multifocal lenses available in the market, like amyopic, bioinfinity, disc lens, EDOF, MiSight, Nature View, and soft okay. So if you see in this study, they found that in study on Juame only, and we found that with different design lenses, especially the this soft okay lenses, had a better inward focusing at 20 degree and at 30 degree temporal. Compared to the other lenses, which is having, if you see the MiSight, which is very renowned lenses in the market, even in that case, a very interesting factor what they found is that at 30 degree temporal, the inward focusing actually converts to outward focusing. So this is the MiSight lens, which is having outward focusing at 30-degree axis. So that is all from my side. I thought to present more about the concept of myopia control in my presentation. So anything else I can, if you want, I can also present on the fitting philosophy of orthokeratology.
I think, Dr. Vikas, you have actually, it was a very excellent and an exhaustive coverage of all the principles in contact lens fitting for myopia control. So, Dr. Rohit, if you would like to add something to the discussion.
So I think we'll take, if there are any questions on fitting, we'll take them there, because I think it's been very nice, interesting, especially about the way these contact lenses act, and how we are expecting that they are going to act on myopia control, because it is definitely a bit different from the way we are expecting. Let's see if there are any questions in the chat, and maybe then we'll take it on with the panel.
Yeah, we have a wonderful panelists with us. I think Dr. Aditi, Dr. Shelja, Dr. Aikeda, Dr. Anu Malik. If you have any comments or any questions, it's
Thank you,
most
Dr.
welcome.
Ravika. Vikash, as usual, excellent presentation, and I'm fortunate enough to be associated with him for a few contact lenses. And he's so meticulous
Thank you, ma'am.
regarding the patients, and the patients are so satisfied. So maybe for the general audience that we have, Vikash, you can, give tips on which patients we can refer for the contact lens, and how to counsel, especially the parents. For orthokeratology, it is very difficult for us also to counsel the patients, to tell them, how this is going to work. So few pearls, if you can share with us.
Yes, ma'am. First of all, there is a myopia control risk factor. So that we need to understand when we talk about the different modalities, especially the orthokeratology or any contact lenses. So there is a study done by one of the Australian optometrists, and he also have a very beautiful website where he have given all the risk factors which are associated with myopia. And even there are a lot of softwares also available nowadays. I will share in my in the link. I will share the link of that, where actually there is a software which actually, if the patient needs to fill the form, where they will ask you that what is the age of the patient, what is the ethnicity of the patient, since how long he is wearing the spectacle, does any of the parents having myopia or not, and also what is the progression, that means in a 1 year or 6 month time, what was the progression of these spectacles. So these all factors are very important to counsel, to understand that what is the risk factor. So once you fill that form, so it will give you 3 criteria, that does that children falls under the low risk factor, high risk factor, or medium risk factor. So based on that, we can go with different modalities of the contact lenses. Not only that, there is one more software from Brain Holden University, and that is also incorporated in most of the instrument nowadays available, like Myopia Master and other instruments, where they have tried to understand that what particular modality is going to help that patient more, means what particular modality will have a better efficacy in that particular patient. So again, there is a software, also it is available online, where you can feed all the data of the patient, and that will tell you that what, if you go with the orthokeratology, or if you go with this soft lenses, or if you go with the other myopic like spectacle or atropine, then what will be the efficacy of that lens. So that is also very, very useful tool for us to understand and use that tool in front of the patient. Even the parents can fill the form if they you don't, means if you just share the link with them, so if they fill the form, they also can understand the risk factor. So that will also help us to motivate them to go for any of these modalities, because once they found that the patient falls under the high risk factor, that their child falls under the high risk factor, then they themselves will be motivated, and maybe that is the best way to convince those patients to go for myopia control.
Absolutely. Thank you so much.
And Mr. Vikas, considering your experience in treating these kids with the ortho-K and contact lenses, so what can you give us any practical tips to the audiences and to the people who have joined in here about how do you decide upon which lens to use, in which, like you told, you decide on mild, moderate, and severe, what is the risk profile of the child? So exactly how do you decide, if you could?
So basically, ma'am, there is a way like even there is a factor like there are 6 points which we know like one is the patient age, how much near work he's doing, means indoor activities, how much indoor activities he's doing. So if indoor activities more than 2 hours, then it is a factor. Then what is the ethnicity of the patient? It's a Asian or it's a other ethnicity. Then any of the parents, like one parent means both the parents are having myopia, then the risk factor is 6 times. And last, what is the progression? So if we calculate all these points, you don't need to go to the software also. You just jot down all these points, and if it is more than 4, that means he have one of the both the parents are myopic, let's say, or the age is less than 9 year, or if the uh, progression is more than 1 diopter per year. So if you tick all this, and if that for if this number is more than 3 or more than 4 in that case, that means that the patient is falls under the high risk factor. So based on this calculation, also we can use this calculation manually, and we can counsel the patient for myopia. One more important factor is that before going for any intervention, but we have understood that the efficacy of this result will be better if we first of all we try to understand the binocular vision of the patient, because all this technology, if we talk about this pencil vision span which I just talked now, so if the binocular vision is not proper, that means it's not aligned, if the patient is having exotropia, so in those cases we are talking about that the parafoveal zone. So that parafoveal zone, the rays which are falling on the parafoveal zone, it will actually not fall on the parafoveal zone if the patient is having a squint. So all this factor also needs to be considered, like we need to take care of the binocular vision. So the first criteria is that when we go for a patient and when we counsel the patient, the first work of what we do is to understand the binocular vision of the patient. So once the binocular vision is well understood, and if we can correct that binocularity of the patient, then we should go for different modalities of the lenses.
Just a kind of advisory or a caution. Remember, most of these nomograms that have been created are either on Caucasians. In a sense, Brian Holden Group has extensively worked in Australia, and on so what they call Asian ethnicity, they are actually meaning the East Asian group of children, where the rate of progression is definitely much higher. So while deciding whether to start myopia therapy or not, it would be preferable to first document progression and the rate of progression, even if by a follow-up of, say, 6 months. It helps us in 2 ways. It confirms us that this child who has come to me first time and is having myopia, and I've prescribed him whatever single vision spectacles for his vision, is progressive myopia and not myopia, because myopia is treated with spectacles, progressive myopia is treated with a whole variety, as Vikas has just mentioned. And the second thing is that I will get to know the impact of my intervention. Again, because now multiple options are available with different efficacies, and they act or are effective in different children to a different extent. So 100% efficacy is really not seen with either of any of the modalities that have been mentioned. So it will tell me that the child was, say, progressing 0.5 diopters in the 6 months I've kept him under follow-up, which translates to approximately a diopter a year. And when I intervene with whatever, whether ortho K, spectacle, or atropine, I would have a baseline to work with and see how efficacious my intervention was. And if I do not find significant impact over the subsequent 1 year which I'm treating, I can think of an additional or a switch therapy. So because myopia therapy now must be individualized and there is no one size fits all, it's very important for us to understand the baseline myopia progression of a child and what Vikas mentioned about the risk factors. So all the risk factors along with the rate of progression makes us decide on the modality as well as the aggressiveness of our intervention. Vikas, just putting in perspective.
Very correct, sir. So, and most important, sir, I also want you to highlight more on the binocular vision factor, because that is also very, very important. I have seen many places people are going for a myopia control without doing any workup on the binocular vision.
So, unfortunately, this is not the forum where we need to discuss extensively on the workup, but please remember the first baseline visit is extremely important, as Vikas talked about binocularity. So, whether there is esotropia or not, even esophorias are linked with progressive myopia, and they require, as Vikas has mentioned, more care to manage them. Ocular surface is another very, very important thing to work up whenever you are deciding the pupil size, the near vision. Many of these children would have a near lag. So they are having a little difficulty in near, or may have initially a near lag. And if you give them, say, atropine, particularly if it's in the higher doses of 0.05, then that may actually aggravate. Or if they have an ocular surface issue and you're giving them contact lenses or ortho-K, you may have a challenge, or the risks increase. So similarly, a child with intermittent divergent squint may not do so greatly with, say, spectacles, because there is a peripheral field that is kind of obstructed by these spectacles. So it's very important that a baseline, very appropriate ophthalmic and orthoptic workup is done, because different baseline disorders may help you to choose what would be the most optimal intervention in these children. And binocularity, their baseline binocular vision, and orthoptic workup is a key component of myopia workup today at a baseline. Vikas.
Thank you, sir.
So I just have a question that in which cases you would consider contact lenses or ortho-K as a first-line therapy for myopia control? Is there any specific indication? Because pharmacological and spectacles seem to be a much simpler approach to the management. Are there any specific indication per se?
So, as I mentioned, ma'am, basically there are two interventions, if you say. One is the means optical intervention and the pharmacological intervention. So mostly what we have seen that most of the means practitioners, they start with, if it's an ophthalmologist, then they start with the atropine or a pharmacological intervention, and then they switch over with both the combination, like atropine as well as any of the optical intervention. So optical intervention mostly works on the same concept as we mentioned, like all works on the same defocus theory. But whatever is the technology, either it's a spectacle or contact lenses or soft contact lenses or orthogratology. So any of these can work, but yeah, there are some limitations, as sir mentioned, that especially in case of esotropia, we don't go with the spectacles. Even the contact lenses also have limitations in those cases. So based on this binocular function also, we can understand that which should be the first option to go for. But most of the cases, if there is, if everything is normal and patient is doing well, and then there is a flow chart available where we can start with different modalities. Like if the patient is having normal, let's say a patient is having only myopia as well as cylinder. So maybe soft lenses, soft multifocal lenses is not a choice. And spectacle also is not a choice if the cylinder is very high. So in those cases, yes, we can go for orthogratology. We have seen that even -3, -4 diopter of cylinder can also be taken care with orthogratology lenses. So based on the refractive error, based on the motivation of the parents and children, we can select the modalities.
Right.
Another additional benefit of ortho-K, which can be discussed with older patients, is that they are actually spectacle free during the daytime. So that can be a major attraction for a little older children, teenagers who are conscious about their refractive error and may not be so keen to wear glasses. So they would be a very good group who can be easily motivated towards ortho-K. Younger children, we are also a little apprehensive, and the parents are also a little apprehensive. Sometimes in the initial period, their acceptance can be a little difficult, and convincing them can be a challenge. But older children who are conscious about their refractive correction, don't want to wear spectacles, may not be so comfortable wearing contact lenses also, especially if they are involved in outdoor activity or sports. For them, ortho-K would be a very, very good option, because it gives both the benefits of myopia control as well as a spectacle-free daytime activity.
Absolutely. Yes. Do we have any more questions? Any comments by the panelists?
Yeah, hi. So, a very nice presentation and a very important topic, very nicely covered. I just wanted to know, how do we decide how much time period do we take? As Dr. Rohit was talking about, we consider about a year to decide whether the patient is responding to this, whether we have a significant, control of myopia and decrease the progression. So, is there a value we should be looking at? What is the percentage of progression that we should be looking at? And also, I wanted to know, the second question was, how are the results if we combine atropine along with orthokeratology? Then, do we have an additive effect? How does that work?
Yeah, as far as the this factor, like what should the so we know that at till the age of 9 years, the progression in Asian eyes is if it's more, if it's if normally it should be not more than 0.25 diopter. So if that is there in within 6 months or 1 year, that the power progression is just 0.25 diopter, then there is no need for any of intervention. Yes, if it is more than 1.75 in the range of 1 diopter, then yes, as sir mentioned, that if you don't want to go for a 1 year waiting time, then 6 months. Like in that case, if the progression is somewhere around 0.5 diopter or 0.37 diopter, then those patients are actually a bit, ideal patient to go for a myopia control intervention. What was your second question, ma'am?
That's right. So I also wanted to know, how do we assess? So what should be the rate of progression when the patient is already wearing ortho-K lenses? And the second question was that, how does atropine along with orthokeratology, does it have, like,
Yeah.
wearing the lenses along with atropine, does it have an additive effect? And does, in patients who you think they are not responding to either one of the treatments, adding another one, does that help?
Right, ma'am. So once we go with the orthokeratology lenses, so as I mentioned that there are a lot of studies. We say that the means the progression can be means limited by 50% to 90%. When we are saying it's 50%, that means suppose the patient power is progressing 1 diopter every year. So if we go with orthokeratology lenses, and we believe that if the average value is somewhere around 50%, then the progression should not be more than 0.5 diopter. So if it is between the progression is in between 0.5 diopter, then that means that technology is working, right?
And I would
All
just
So
like to add a point that, as Dr. Roy just pointed out, I think it's the baseline progression. We should always wait and assess the baseline progression. So once you have got a baseline progression in the previous year, and then when you start the therapy, you'll get a better idea of how well it is able to control based on the baseline progression. So
right.
if it was
So
0.5 diopters a year, so whether it's worked or not and how much it's working, you get the idea. So even if you get some benefit, maybe you can continue the treatment and then consider adding maybe another treatment if you want to, based on the response.
yeah, as far as combination, yeah, there are studies we say that there are a lot of studies nowadays where they have used both the modalities like atropine and orthokeratology or other optical intervention, and they found the results are better with those with the combination therapy.
So absolutely, additive effect is there. But again, the point is that whether you need to add or you need to switch, you'll only get to know after you've had an idea of about the impact of that treatment on the rate of progression. So that's why it helps to know the baseline progression. So additive has been shown to, especially many studies have now come, atropine with ortho-K showing definitely better results than either of them alone. And I
Thank
think
you.
Dr. Geda has raised a very, very important point. I think these are very, very fundamental questions that we still find challenging when we are, following up or managing a child with progressive myopia.
I have a question, sir. Taking into account your experience with Ortho-K, are there any long-term safety and efficacy complications regarding orthokeratology with regards to corneal infections or endothelial cell damage?
So there is a study. So we can say there is a means they have taken the reference of a lot of studies, somewhere around 170 studies on safety and efficacy of orthokeratology, and they found that within a year, 7 patients out of 10,000 is having complications, and that complication is not very very significant. So nowadays, because initially there were a lot of complications with the orthokeratology lenses. The reason was that time they were using a low decay value contact lenses. But now after there was I think 10 years back, there was a big challenge related to complication with orthokeratology in China. So that time the regulation came that none of the orthokeratology lenses should have a decay value less than 100. So nowadays all the lenses which are available in the market is having a decay value more than 100, and that is why the complication rates have decreased a lot. There is one complication which is very common now we have seen, that is the epithelial staining. So that is very common in orthokeratology lenses, but there are studies which say that this actually means once the patient start using the lenses and after few adaptation, so they say that there is an adaptation time, and after some time this epithelial staining goes is not there. So maybe after find epithelial staining in the lenses, but as the time progresses and the patients start wearing the lenses, that also is not there. Sir, your feedback, sir, related to complications.
I guess, although we are particularly concerned, as Anu being a cornea specialist, is about the risk factors to the cornea. Most studies have not found it to be significantly higher than general population of those children who are using other soft contact lenses. But obviously in a country like India, where not enough data is still available, you must remember that you need to be a little more cautious about these. But highly successful interventions are now, I would say a lot of children are now on it. So I would not consider that as a significant reason for not starting or not pushing children towards ortho-K. But again, you have to be a little careful and choose very carefully what is the intervention, because in Indian setting, you need the parents to be a little more hands-on when it comes to providing ortho-K or soft contact lenses as a treatment option, as compared to, say, atropine or spectacles. So that's what our experience would be, but I guess.
So this is the international study. They have done a study on comprehensive review of 170 studies, where they found that 7.7 cases per 10,000 per year is having the risk, and that risk is not very significant.
Dr. Shailja, you had a comment?
No, I was just wanting to add, excellent talk, Vikas, and great discussion. The Indian scenario, as Dr. Rohit Saxena was mentioning, it is a little difficult for what I have seen, that the parental acceptance for a contact lens in children is quite low, because one is their fear themselves to, difficulty in inserting and removing it, because they'll have to do it themselves. And because most of our generation people are also not contact lens users. Either people go for LASIK here or they wear glasses, right? So we are not trained. So, it's difficult for us to use as compared to the Western counterpart, where, people are more used to contact lenses. They don't, they wear it quite often throughout their childhood. So they are easy, it's easy for them to use on their kids. But the real acceptance which I have seen in some of the patients are those kids who are very good in extracurricular activities, or stage shows and all, where they don't want to wear glasses, at the same time they are progressing. So those kind of patients are really the ones who accept ortho-K much better than the other patients. And the second reason of acceptability is the cost of these lenses, which is still so high. And since last 5-6 years, I've been hearing about ortho-K and it's not come down. Most of the other things have come down. Even genetic testing has come down under last 5 years when I've been started to do it, but ortho-K costs have not come down. So what are your take on it, and how do you think of making it more accessible to public, so that we can really know ourselves how much it works?
Vikas, to this panel, you have to provide it much lower cost.
Yeah, very true, ma'am. But the reason is just the demand and supply. So now, orthokeratology is very less used in India, and I think we are we are selling more than any other company in India. We know that it's very low. So because of this only, the price is very high, and we are not in the position to negotiate with the parent company to decrease the prices.
So it's a chicken and egg
Secondly,
situation. No, you have you have
right.
to lower the prices, your sale will go up.
So we
yeah.
we are ready, ma'am, but it's all means the parent company are not actually ready to give us at lower price because we have very
Yeah,
low volume.
agree.
Secondly, ma'am, related to contact lens, ma'am, you are right, ma'am. In India, in Indian scenario, the contact lens users are very low, but and the reason is because of this environment, the dusty environment, right? So that is one of the factor which people used to say that. But the best part with orthokeratology is that you are not going to use these lenses in daytime, right? So so there is no
Yep.
dusty environment. So because you are wearing these lenses while you are sleeping. And most importantly, whenever we counsel the patient, whenever they are going for orthokeratology lenses, that once you are ready and you are sure that you are going to sleep, and even you are not going to use your mobile phone also, then only you have to put the lenses. So and that is because once you are opening your eyes and you're blinking, the lens will move, right? And if the lens will move, it will create a molding in different places. And that can also cause lots of halos, means complication in the patient, means their visual disturbance will be there. They will have halos and other visual symptoms. So we just need to counsel the patient that these lenses are not you're not going to wear these lenses in the daytime. So there is no factor of dusty environment or something like that. So these lenses are better compared to this the day wear lenses.
Yeah, I think so. That's quite an interesting discussion we had. So this almost brings us to the end of the session. And I think any concluding remarks, Dr. Rohit?
So thank you, Vikas, for highlighting and bringing forth a very, very important armamentarium for the management of childhood myopia, which is becoming a very major challenge for us as ophthalmologists and as parents and as caregivers to children. Before we close, I think while we have discussed all kinds of intervention modalities, the single most impactful intervention is lifestyle modification. I've been saying this now for a very long time. Myopia is the youngest lifestyle disease in human beings. And just like you can't treat diabetes without reducing the intake of carbohydrates and total calories, you cannot prevent myopia progression significantly without advising the child, involving the parents in lifestyle modification of the children. So chair time, discussion with parents, trying to evolve a comfortable modification in the lifestyle of the child, because each child has a different lifestyle, different desires, different interests. So we need to work around them and ensure that a good lifestyle change is possible, because however good the intervention in studies, real life impact on a child will only be when we have a multimodal intervention, which includes lifestyle modification. So like I said, thank you, Vikas, for bringing forth a new intervention not so well explored in India and increasingly becoming an important alternative for us. So it was very important for us to be aware of this and try to see how we can fit it into our armamentarium for managing childhood myopia.
Right.
Goodbye.
Thank you. Thank you, sir. I think it was a wonderful discussion and it added to, I think, everybody's knowledge a little bit more. So with this, we come to the end of this session. Thank you, Mr. Vikas. Thank you, Dr. Rohit,
Thank
Dr.
you, ma'am.
Praful.
Can
And I'd
everybody
like to
put their
thank all
screen
the
on? We'll just take a
panelists.
screenshot. Everybody
Yes.
put your screen on.
Can
if
we have a
possible.
screenshot, please?
Sharik, if you can take a
Videos, yeah.
screenshot.
Is anybody taking a screenshot?
ये सबसे बड़ा question तो ये है.
Yes. Has it been taken?
I did. I'll send you.
Thank you.
Super. Thank you.
Thank you, everyone.
Thank you. Bye-bye.
Thank you.
Thank you.